health committees. Thank you for taking the time to listen to our testimony today. My name is Katy.McFadden. I'm a registered nurse certified in neonatal intensive care. Last month, I resigned from my position as a staff nurse in the neonatal intensive care unit at SUNY Downstate Medical Center in East Flatbush, Brooklyn, where 90% of patients are of African descent. In the 5 years I worked for Downstate, I cared for many patients who died or suffered permanently worse outcomes for conditions we know how, but did not have the resources to optimally manage and treat. I frequently worked shifts with half the nurses we would have needed to meet national safety standards. Even when we managed to get through these shifts without major medical errors, which were common and are common, our fragile patients still suffered. Babies do not cry while they're in the womb. And when they're in the NICU and only receive a fraction of the care that they need, prolonged cry times create a toxic level of stress hormones that forever changes the way their brain forms. Working in an under-resourced NICU, I could literally hear my patients' neurodevelopmental potential diminish as I focused on higher priority and life-sustaining care. Downstate's NICU also lacks a lactation consultant, physical and occupational therapists, mental health services for parents, a developmental care specialist, a peer support and volunteer coordinator, and a dedicated nurse educator. Services NICU babies need not just to thrive, but simply survive. Some of these absences were in direct violation of state regulations. All are considered standards by relevant professional organizations and are common in other level 4 NICUs. Less than 10 miles from predominantly white-serving private hospitals, conditions at Downstate are worlds away, and it shows an exponentially worse hospital and population-level outcomes. In 1850, our Constitution counted most Black people as 3/5 a person, and the white-Black infant mortality rate was 1 to 1.5. In 2019, the public insurance covering the majority of Black birthing people pays half as much for obstetric care as the private insurance covering the majority of white birthing people. And the white-Black infant mortality rate is worse at 1 to 2 to 3. The largest single driving force behind racial disparities in maternal infant health outcomes in New York City is the lower quality of care provided at a concentrated set of minority-serving hospitals. Quality is worse because staff and services are missing. Staff and services are missing because we cannot afford them. We cannot afford them because reimbursement from public insurance are considerably less than the true cost of care, and we care for a disproportionate amount of patients on public insurance because of historic and ongoing racial segregation and economic disenfranchisement. Even in neighborhoods with better funded and safer private hospitals, widespread, illegal, yet unchallenged insurance discrimination causes de facto racial segregation. We've never stopped having racial health disparities in this nation because we've never started valuing the lives of all people equally. A single-payer system eliminates the funding disparities that drive the racial disparities in New York. It eliminates the burden of underinsurance and high out-of-pocket costs that make necessary quality care still out of reach for birthing people and their families. For this and for all of the reasons presented before you today, I urge you to pass the New York Health Act. Thank you for your time.
Greetings, Chairman.